Dr. Berg. I'll welcome to the stage Dr. Hansra to defend the opposing view.
All right. Well, thank you everybody for having me, and my first time to Houston Shock, and I really hope I get invited back again, because I think in the next 10 minutes, I'm gonna make a very convincing argument that an intensivist is an intensivist no matter what. And although my colleague Dr. Berg brought up a number of great points, you guys all look like a very, very smart and intelligent group. You're gonna see right through some of those holes that he left for me. All right, so getting right to it, is a critical care cardiologist fundamentally different from other intensivists? I think not. This is what we're gonna go over. We're gonna talk about what is an intensivist? What are the educational requirements? Because if we're not talking about the same language here, of course there's gonna be a difference in perspective. What's the role of us in an ICU setting? And more importantly, thematically highlighting our similarities rather than our differences. So let's just go into definitions. What's an intensivist? It's a physician who can manage critically ill patients in the ICU. And by the ACGME, critical care medicine is the internal medicine subspecialty that focuses on the diagnosis, management, and prevention of complications in patients who are severely ill and who usually require intensive monitoring and/or organ system support. Super dull definition, but it has to be said because this is what our governing bodies are highlighting for us. Note there that there doesn't mention any specific organ system, it doesn't mention cardiology, pulmonary, anesthesia, because the ethos of critical care medicine transcend any one organ system or subspecialty. Because you don't have to take my word for it. If you are a fan of Shakespeare, what is in a name? We as a society, and as providers, and as Dr. Berg mentions, we are critical care cardiologists. Critical care being the operative word, not cardiology. Otherwise, we can always reverse it, but we choose not to. And so this is going to be really important for us going forward. Now, what are some of these themes? We all share core skills and training. Again, intensivists, regardless of their subspecialty, share a fundamental skill. We want to be able to manage the ventilator, hemodynamics, and multi-organ failure. And this knowledge is required to manage critical situations, and it applies universally, whether you are cardiology, pulmonary, anesthesia, emergency medicine. And integration of knowledge from various different specialties is what makes an intensivist such an outstanding physician to be able to deliver great care to patients. Again, ACGME defines critical care training, which is identical across subspecialties. An intensivist, regardless of their training, has undergone rigorous education in critical care medicine that prepares them to handle a variety of life-threatening conditions, not specific to any one organ system. Now, I'll give you guys a few life examples. So this is Dr. Dennis Phillips, who is one of my colleagues. And these, you guys can see, there's a lot of lovely quotes about Dr. Phillips. Now, Dr. Phillips attended in our CICU at UPMC, and fun fact, he was not a cardiologist. He trained in anesthesia, then did critical care, and then did cardiac critical care, and was still regarded as one of the best attendings that has come through the CICU at UPMC. Somebody who might be a little bit closer to Texas is Murad. He's over at Baylor. And Murad was also a fellow at UPMC. However, his training was a little bit different. He did internal medicine, and then he did critical care. Then he came to UPMC for his cardiology fellowship. And these are some of the things that they said about Murad. The unit felt safe when Murad was on. Talk about someone operating at an attending level. Hire him. He is seamlessly integrating critical care cardiology with his patients. And he also identifies himself as an intensivist first, then a cardiologist. Anybody who's done training knows that to convince a CICU nurse that you are the real deal is pretty convincing. And it wasn't because he was an outstanding cardiology fellow. It was the fact that he was critical care trained, and the skill sets that he brought to the unit were far superior than anybody else. And there are some others. Eugene at NYU, cardiologist turned intensivist, recognizing how important it is to be a general intensivist rather than an organ specific. Even Rand Lee, who is an outstanding husband and dad, but also reports a critical care and heart failure trained. I mean, you guys see the themes here. It is across the spectrum. It is across our country, across different institutions where people are recognizing the role of an intensivist first. I probably could just stop right here and get off the stage because I think I've already proven my point, but I have a few more slides to go through. We are a unified field. Too long has cardiology lived in a silo where we think we are the princesses, the kings and queens of the castle, and we don't have to do what anybody else does. I think that is gone. An intensivist, again, refers to a physician trained to being able to manage critically ill patients and provide holistic care. How often are we thinking about all the different organs because we are trained in intensive care, not only the medical problems, the surgical problems, and being able to deliver that to our patients is the most important thing, rather than just one organ system. Not only are we a unified field, but a unified goal on focusing on acute needs. So again, intensivist, no matter where they come from, stabilize patients to maximize chances of recovery. That is why somebody comes into an intensive care unit. They need to be able to have support. Life-saving interventions. Now, these aren't very specific to any one person. Everybody knows that you got to be able to put a central line in if you're in the emergency department, you're on the floors potentially, you're in the critical care unit, and a number of different providers can do it really, really well. Another example. So Jonah Ludmir, he's at Mass General, which is actually just down the road from the Brigham, and he's an assistant professor of medicine. He attends in the CICU, the CVICU, and the MICU. So his skill set can transcend any intensive care unit because of the foundational skills he's developed in his training. Another leader that Dr. Berg highlighted was Andrea Elliott, and this is from an interview that she had that I work at the University of Minnesota. I dedicate about 13 of my 21 weeks to the ICU. I'm primarily in the CICU, but I spend time in the CVICU. I also dedicated time to the MICU, a commitment that intensified during the COVID pandemic. I don't know about anybody else, but I was happy to see any intensivist come through and help relieve when we needed attendings for a COVID ICU. And in fact, Dr. Elliott has gotten many educational awards from the critical care community on how strong her efforts have been to advancing this profession. Now, this slide's a little bit wordy, and I apologize for that, but our shared approach to patient care, interdisciplinary teamwork is really important. We have to be able to collaborate with specialists from various groups to be able to provide comprehensive critical care. Just like Dr. Berg mentioned, we're the quarterbacks. It doesn't mean that a critical care cardiologist is a quarterback. It means that the intensivist, that is the theme here, the intensivist is the one that is the quarterback. We integrate this knowledge seamlessly. And although a cardiologist has in-depth knowledge of cardiac issues, the intensivist is the one who ensures that this is being delivered to the patients and it's not being missed in other areas. I'll give an example of myself. I have both worked in a medical ICU and a surgical CV ICU as well and thrived. I was welcomed because of the foundational knowledge I had in critical care. And so this was something that was really important from both my professional growth and journey. We use similar technology and procedural competencies. We all know how to use a ventilator. We all know how to use A-lines. And understanding these diagnostic and therapeutic technologies is very similar. That is why you do a whole year dedicated to intensive care. Procedures even, central line placement like I mentioned, intubations. Emergency medicine can intubate, internal medicine, critical care, ECMO. Interventional cardiology knows how to cannulate for ECMO. Surgical teams know how to cannulate for ECMO. I was cannulating for ECMO at my previous job as well. And so this is not an organ-specific procedure. It is standard procedures used across various types of critically ill patients, regardless of the condition. Even our evidence-based practices, so there was a lot of data that was presented, a lot of, we can argue about registry data until the cows come home, but I won't do that because, like I said, you guys are a very smart group. You guys can see through Dr. Berg's arguments, have a ton of flaws in them based on what he presented. So going back to this, evidence-based practices apply to all intensivists. Regardless of what the guidelines say, we know how to manage sepsis, sedation, fluid resuscitation, and that does not apply to any one specific person. We have standardized ICU care around ventilators, ICU checklists, infection control, nutrition, and this is all of the things that we learn as intensivists, and it's not restricted to just one organ. Remember, it is a holistic approach that we are giving to our patients. Final example, you guys may have heard of this guy, Jason Katz. He was just here a few minutes before, incredibly handsome and charismatic, but this was in an interview that he gave, that you direct both the CICU as well as the cardiac surgery ICU. Are there lessons in each unit that make you a better doctor? This was his response, not mine. That's something about my job I really like. I feel comfortable managing both surgical and medical patients. This motivates me in my clinical and research growth. I mean, if the president of the Society of Critical Care is making this statement, me as a simple country doc from Nashville, I will just leave it at that. And here we are today. So, in summary, I think we all can see an intensivist is an intensivist. We share a common approach to patient cares, and while the subspecialty expertise in cardiology can influence certain treatment choices, the core functions and our responsibilities remain consistent across specialties, making our role fundamentally the same regardless of the specific training we've had. Thank you.
All right, well, the gloves have certainly come off. To start our discussion, I'm actually going to ask everyone, including our panelists, to vote. Raise your hand if you think a critical care cardiologist is a unique entity. Pretty good. Oh, no. Dr. Berg, you know you've done a good job if your opposition has sided with you. And then raise your hand if an intensivist is simply an intensivist.
There's nothing simple about being an intensivist.
Excellent. So why don't you kick us off?
Okay, so my name, again, I introduced myself. I think there is no question. We've been waiting for you guys to come to the table for a while, because a lot of intensivists have long realized AMI shock is an entity that is continuing to improve in terms of, like, yes, you recognize it's AMI shock, but the outcomes have not improved. Decades, right? So we've been waiting for you all to come to the table. There's no question. It's just sad that it took until 2025 to get there. So bravo, Jason, absolutely. But the fundamental truth is economics, okay? You tell me how many years it's gonna take to deploy a workforce. And what is it? I just calculated, 11 years, 4 years med school, 3 years internal medicine, 3 years cardiology, and a year of interventional, or the intensive care. A few more years of interventional cardiology, a few more years of advanced heart failure cardiology. We are already, we keep training. Is it good to have Jason Katz at the bedside when an AMI cardiogenic shock comes? Absolutely. But how many more years is it going to take to have more Jason Katzes? So as you guys are doing this, we have to have a parallel pathway. The parallel pathway is you have 30,000 global intensivists that are ready to go, that are already trained, that are already board certified. Create a pathway for them. This is the number of months you need. This is the number of PA CATs you need. The PA CAT story, how many years are we going to hear it? That's because of a trial? Yes, the MICU, we take ownership of that. I speak on behalf on all the MICU docs. We saw randomized control trials, and then, you know what? Training has gone down in terms of the number of PA CATs. But it's actually not as hard as you think to increase the amount of PA CATs we can do in the MICU. Guess what? They're all our patients. If they need a PA CAT, we can get our favorite cardiologist to come, get certified in 10 to 20 of them, just like you guys have proven that ICU intubations are not that hard for cardiologists. Anything is not hard if you want to put in the work for it. But as you all go through this, if we do not have a bridge pathway where you integrate with pulmonary critical care, surgery critical care, CV anesthesia to create a, cardiologists love short pathways and long pathways, I demand that you create a short pathway for the existing workforce so that the people that are there at the bedside, instead of waiting for the 10 years where there will be 15,000 more cardiologists that are critical care trained and the mortality remains the same way, we need to address that. We can't show PA cath data from national inpatient sample that it's going down, we can show the same thing. Let's just make it APC, our program director council is right here. We mandate that any intensivist that get trained anywhere in the world needs to have this many. And if that is the supply issue, we can take care of that. Number two, I just ran into my fellow who graduated 5 years ago. She was in a small town. Patient is coding, cardiogenic shock. She assisted, she made sure ECMO was put in, she sent the patient. I cannot demand a critical care cardiologist. There is no way economics will sustain that person to go to Lufkin. Forget like Lufkin. I can't even ask for 30 minutes outside our med center, right? So I go back to economics, efficiency, short, long pathway. If we really are going to say that we are inclusive, which was on your slide, number 2 or 3, Jason, that inclusivity comes from not just demanding. I can barely handle one cardiologist in the hallway. I want to know the critical care cardiologist that is so many buddies with 5 other cardiologists and saying he's the quarterback. I actually want to see it. It's really difficult because you know who the captain of the ship is? The patient. And the last thing the patient needs is egos in the hallway. So the beautiful thing about an intensivist, as they said, the intensivist recognizes the only captain of the ship is the patient. And to really provide optimal patient outcomes, we need to work together. We need to deploy the workforce. We need the APPs to be trained. We need the existing intensivists to be trained as you guys build it out. That's great. When I started Pulm Critical Care, there was not that pathway. All I knew is I belonged in the ICU. I did Pulm Critical Care. I found the right mentorship. Dr. Nathan is here, Dr. Carr is here, Marwan, Sachin, all these people that came through the unit, we built the units together. You need that redundancy built into the system. The pulmonologist adds value, right? Otherwise, you're going to have the same bricks lining up, and the holes will be the same. I end.
What do you guys all think? Thoughts?
Well, I'm hesitant to talk because I feel like I'm going to spill all my slides out on this discussion. But I think that there's sometimes when you try to put things into bucket as we do with diseases, we recognize that that's not as easy as, nobody fits neatly into, I do pulmonary hypertension, and it's very hard to get somebody who's pure group 1 PH, right? PAH. I feel like it's the same way a little bit with critical care cardiology. What I would say is the more important thing, and the thing that as a cardiology community that hasn't been fully transitioned over yet, and I think is a great first step, is that there needs to be high intensity staffing. So this goes along with what you're saying. In fact, actually, there was some data out there that I was reading as I was preparing for this that suggested that although a majority of CICU directors believe that high-intensity staffing is the right way to go, we know, and I'll present this literature, it's already been presented in part, that high-intensity staffing leads to a multitude of better outcomes. The majority of level 1 CICUs are not staffed in a high-intensity model. I think in 2025, that's a problem that's solvable, and probably we should aim for that as a first step. It's going to take us a long time. I don't even think there's 200 critical care cardiologists in the world today. At the rate we're going, I'm going to be dead before we can fill all of those ICUs.
Absolutely.
And I'm still pretty young. And I think so where do we go in the interim? And I think that is to focus on high-intensity staffing as our first step while we backfill with critical care cardiology.
I guess I would say that the economics are certainly a consideration. The training pathways we can't ignore. We are a finite commodity, and we are not rapidly growing just because of the bottleneck in training. That leads to questions about what we do for short-term sustainability, but also the vision for where our field goes long-term. And I think that if most of us were asked, would you like your parent or your spouse who comes in with an acute stroke to be cared for in an intensive care unit where there is a provider who can provide the neurology care as well as the critical care in one person and seamlessly provide both of those skill sets versus ICU where you will have a medical intensivist, I think most of us would choose the breadth of skill sets embodied in one person if that's possible. Now, from a cardiology standpoint, I think that one of the things that makes us unique as cardiologists are that we don't just look at labs every day in a computer and kind of come up with a plan. We have the ability to acquire and interpret our own primary data. And so that means that we're able to look at CAS, look at echoes, look at the TEE, look at the EKG, monitor the device interrogation, put all of those things together and come up with a plan based on the pathophysiology, and then account for, when we're a critical care cardiologist, the additive component of taking care of the concomitant critical care illness. And I think the long-term vision is that we strive to train as many people as we can to be able to have that cardiology skill set, knowing that it's going to take a while for us to get there, but that's aspirational, and I think that it's probably the best thing for our patients.
Yeah, no question about that.
Yeah, and so I guess that I would say one of the things that from a society standpoint that we've talked about, and especially with partnering with the Association of Pulm and Critical Care Medicine Program Directors, is in the short term, actually, how can we be a value add to pulm and critical care medicine training? There are tons of our colleagues who give your time and love our patient population also, and how do we do the reciprocal? I am indebted to this man right here who helped train me at the Cleveland Clinic, and so how do I continue the converse of that and help our pulm critical care colleagues who have interest in this patient pathology also. And I think that that's one of the good things about us coming to the scene and formally organizing is that maybe now we can have some bidirectional paths forward to help improve the care of this patient population and bring in all interested parties that really care about this pathology and this patient population. I think there's a question out there.
Oh, please.
All of you for developing this nascent specialty, which I'm sure will succeed and thrive. I'm Marv Constant from Tufts Medical Center. I ran our cardiovascular center for the last 15 years, and I would say if we had a motto across our cardiovascular center, it was teamwork. And what we did that was unique was we broke down barriers between cardiologists, cardiac surgeons, vascular surgeons, and critical care folks. So I want to just tell you two quick stories. One is that if you go back 7 or 8 years, we had no critical care presence in either our cardiac CCU or our cardiac surgery ICU. So I, as a heart failure attending, would be the primary caregiver of somebody that's in the coronary care unit or the CSICU. And I can tell you that it was clear to me that we were screwing up and that we needed to have critical care specialty there. And we partnered with our Department of Anesthesiology because we couldn't find a cardiac critical care person, okay? But we partnered with our anesthesiology department, and we put together and then brought in the pulmonary critical care folks to all partner with us in building a cardiovascular critical care program that covered the CCU and the CSICU. And one of the secrets is that the relationship between our critical care folks and our heart failure doctors, which I'm most familiar with, is just incredible. There are no egos. I round on those units, and it's just the teamwork is the key. But I have to say one thing, that I remember the first time attending on the heart failure service and caring for a patient who was in the coronary care unit. And it was the first time I rounded with a critical care expert. And we rounded on the first patient. We rounded on the second patient. By the time we got to the second patient, I said, oh my God, I've been ignoring 80% of the patient all these years. And to show that I cannot believe that we tried to care for those patients all those years without critical care specialty. So that's one story that you can glean whatever you want from it. The second story I'm going to tell you is when the Heart Failure Society of America pushed very hard to have a secondary subspecialty of internal medicine of the heart failure specialist. It took us 4 or 5 years to convince the ABIM to do this, and that's a long story. But one of the debates that was having, where this resonates with me, there were people who were saying that you don't have to be a cardiologist to be an advanced heart failure doctor, okay? That you could go right from internal medicine without a cardiology fellowship. And I almost passed out, okay, when I heard this. You know, knowing, and you guys, you know what you have as a cardiologist in terms of your ability to look at coronary angiograms and look at echoes and deeply understand hemodynamics, and to think of all those things that you're missing from an internist trying to be a advanced heart failure doctor. And I think there's some analogy here. I say there's room for both, and there's no reason why you guys have to take over all of the ICUs. There are plenty good people there. They need to, if they're developing as a critical care person, they have to have exposure to cardiovascular critical care. But it would be great to have a unit of mixed folks, of people who are pulmonary critical care, maybe anesthesia critical care, and let's get the cardiac critical care people in there as well.
Thank you so much for those wonderful comments. We only have about 2 minutes before we need to take a short break and then actually transition to what will nicely follow this, the conversation around training the critical care cardiologists. But any final comments to what we just heard?
I think one of the most important slides was Dr. Berg's first or second slide, which showed the huge increase in sepsis, renal replacement therapy, ventilator use. The cardiac intensive care unit is no longer the defibrillation unit. And so I think the justification in some ways for our specialty is despecialization in some ways. For most of us, it was a very focused cardiovascular pathway and then critical care at the end. That's obviously, there are exceptions to that rule, but I think it's very helpful to take a step back and have that extra breadth of training. And Dr. Chasen also taught me this, that there is 80% of the patient that we need to think of. I do think it is important to have the cardiac foundation, and you know, I can't tell you how many times we've admitted patients with pneumonia, and we've looked at our primary data, and I said, you know, that MR that has not been commented on in the report is severe. And I think that having the ability to look at your own primary data and care fully for the patient is really the whole point of all of this. And that also goes back to teamwork. I think that we've heard team of teams again and again. I think if we all have the compassionate assumption that everyone is trying to do the best thing for the patient, and we can check egos at the door, I think that there is room for both intensivist and cardiology collaboration as well as dedicated critical care cardiologists.
Fantastic. With that, we will take a short break and turn over to our next session, and we'll continue to have these discussions. Thank you all so much.
Thank you. Really nice to meet you.
Nice to meet you.